Hello, everybody. Thank you for coming to our job talk for Karen Hampanda. She is interviewing for a social epidemiologist / mental / behavioral health faculty position that we have open in our department. And she comes to us she is currently a postdoc in the Department of Community and Behavioral Health. And she has an MPH from Boston and a PhD from the Health and Behavioral Sciences program at the downtown campus. Her research focuses on identifying and addressing social determinants of maternal and child health as related to HIV. And she has various projects, but some of her focus is in Africa. And she's currently a principal investigator on a K99R00 that is aimed at developing an adaptive couple counseling intervention and testing its effects on HIV outcomes in an RCT in Zambia. So thank you for coming.
Thank you. I apologize. I am fighting off something like everybody else. But I'm Karen Hampanda, and I really appreciate the opportunity to come and present on some of my research today, titled Social and Behavioral Factors Associated with HIV Outcomes During and After Pregnancy. And this might be slightly ambitious, but I'm going to be attempting to present from 2 different projects in 2 different geographical areas from Zambia and Kenya. Oh, I wanted to double check, I'm sorry. Should I go 45 minutes? How much time should I leave for questions? Do you know?
I'd recommend about 45 minutes.
Okay.
Sometimes there's classrooms that are trying to get in and
Okay.
might have to get out.
Great. So just a little bit about my background. As Tess mentioned, my research focuses on the intersection of HIV and maternal and child health and some of the psychosocial factors that influence important outcomes. So in this presentation, I was first just going to go over a little bit about the health topic on mother-to-child transmission of HIV, and then followed by some of the details of these recent projects I've been working on, and some of what I consider to be the most significant, interesting findings. So in this talk, the primary focus is on prevention of mother-to-child transmission. And here are some estimates to just give you a bit of background on the population that's at risk and the incidence of HIV infections in children, which are mostly attributable to mother-to-child transmission. And in terms of the size of the population, I'm a global health person, and globally there are an estimated about 1.5 million pregnant women every year who are living with HIV. And the vast majority, over 90%, live in sub-Saharan Africa. And as you can see from the image here, the incidence of new infections among children has been dramatically declining, and I will show you why in just a minute. But it's still estimated that there are over 100,000 new pediatric HIV infections annually still occurring. And the prevalence of children living with HIV is estimated to be just under about 2 million children, again, with the vast majority in sub-Saharan Africa. So fortunately, we have these very effective both biomedical and behavioral interventions that can prevent mother-to-child transmission. And without any intervention, the risk of transmission is estimated to be about 40%. So 4 in 10 pregnant or postpartum women living with HIV are expected to transmit the virus to their child during pregnancy, labor, delivery, or breastfeeding. However, with these specific interventions, which I will discuss, the risk is lower to less than 5%, and in more recent studies, they're actually estimating it to be less than 1% in a lot of samples. So the interventions that are really important for this population are first starting with HIV testing and diagnosis during pregnancy. So pregnant women come to antenatal care, they're tested for HIV, and if they are positive, they are to start lifelong antiretroviral therapy, which I'll just refer to as HIV medication throughout this presentation. During the postpartum period, it's important that that medication continues. The infant is also supposed to receive HIV prophylactic medication. And then there are specific infant feeding recommendations for this population as well, which is something that I have been very interested in. So HIV can be passed through breast milk. However, in these low resource settings, it is recommended by the World Health Organization and almost all country national programs that HIV positive women exclusively breastfeed to 6 months, followed by the introduction of complementary foods and continued breastfeeding to 12 months. And I can go into, I see some eyebrows raising, I'm happy to go into details about that recommendation, and that's one of the behaviors that I will look at in this study. And then the final step is HIV testing of the infant to confirm whether or not that infant has contracted the virus that needs to also be put on treatment. So as you can imagine, in order for these interventions to be successful, we have to have a high level of adherence, which is what my research has focused on, is these health behaviors. Because without optimal adherence, when women are not adherent and they're lost to follow-up, not only does the risk of mother-to-child transmission increase, but there are also poor maternal and child health outcomes. So the risk of drug resistance for both the mother and the child becomes highly problematic, as well as the increased risk of maternal HIV disease progression and maternal mortality. So, as you would expect, as these interventions have been rolling out, primarily throughout sub-Saharan Africa, but globally, there has been tremendous declines in the incidence of pediatric HIV infections. So this graph just juxtapose on the left, yes, the incidence of pediatric HIV infections as the percentage of pregnant women who have access to HIV medications to prevent mother-to-child transmission has increased. So as we have increasing access, we have decreasing incidence. And currently it's estimated, the most recent estimates were from 2016 in sub-Saharan Africa. Close to 80% of all pregnant HIV-positive women are considered to have access to these medications and to prevention of mother-to-child transmission. And in some of the settings, there is actually over 90% coverage, particularly in this Southern Africa region. Despite this increasing access, we still unfortunately continue to see some suboptimal health outcomes. For example, HIV remains the leading cause of death among women of reproductive age in some of these high prevalence settings. And we know that viral suppression, which I'll talk about a little bit later, is not as low as we would like it across these populations. And we still struggle with issues of non-adherence and attrition. So my research focuses on these two high HIV prevalence settings in sub-Saharan Africa. The first study I'm going to talk about takes place in Zambia, which is located in southern Africa, and the second is in Kenya in East Africa. And these locations both continue to have an estimated national maternal mother-to-child transmission rate of over 10%. And as I mentioned in the beginning slides, if women are adherent to those interventions, it should be down to 5%, 1% ideally. So we still have some progress that we need to do in these settings. The first project I'm going to talk about takes place in the capital city of Zambia. I think this is an important context. So this is the capital city, Lusaka. It has about 1.5 million people living in this setting. And I put this picture here just to show you that this is a very urban setting. Sometimes when you say you work in Africa, people have a different picture in their mind. This is a very urban setting with, in terms of resources, probably being the most highly resourced area. And one of the reasons I chose to focus on this is because I'm looking at health behaviors, and I wanted to work in an area where there were at least the least amount of health system barriers that we were going to encounter. So overall, there are 24 public clinics in this city, and they all offer free PMTCT services and HIV medication. And my project worked at one of these government settings, that is in a compound which is a really highly densely populated, low socioeconomic area called Kanyama. I don't know if you can see this is a Google image, but all of those dots are, like little houses and very, very densely populated, low socioeconomic area. And the methods for this project that I'm going to talk about come from a cross-sectional survey with 320 postpartum women who were living with HIV. And we recruited them at Well Child Care, primarily during pediatric immunizations, because most women, regardless of whether they're adherent to the HIV protocols, they do bring their child for pediatric immunizations. And the outcomes that this project was looking at were women's self-reported adherence, which I recognize as a limitation, to their medication during pregnancy and postpartum, to giving the infant prophylaxis, the infant feeding recommendations that I talked about, as well as infant HIV testing. And the exposure that I'm going to present findings on focuses around intimate partner violence. And in this study, intimate partner violence was identified through women's reports of experiencing physical, sexual, or emotional violence. And I'm happy to go into some of those details about why we measure it that way. And it was measured using validated instruments that we administered by local interviewers in the local languages to women at the clinic. And the following slides will present on some of the analysis with the multivariable prevalence ratios that I conducted in Stata. So the first outcome, medication adherence during pregnancy. Of the sample of 320 women, 270 of them reported that they were offered medication during pregnancy. And among those, there was an exposure prevalence of intimate partner violence at over 60%, which is very high. And of those who had experienced IPV, intimate partner violence, almost half were not adherent to their HIV medications during pregnancy. And those who were non-adherent had close to 2 times the prevalence of intimate partner violence, which was statistically significant after controlling for covariates, both that are important in the literature, as well as your standard demographic covariates. So controlling for age, the infant age parity, woman's knowledge around prevention of mother-to-child transmission, the time of diagnosis, her highest educational level, and I also created a standardized household wealth index that was in this model as well. The second outcome looked at was medication adherence postpartum. 285 women reported being offered medication during this time period. And again, around 61% of women reported some form of intimate partner violence. Of those who had experienced intimate partner violence, 40% were not adherent to their HIV medication postpartum. And over 2 women who were not adherent had over 2 times the prevalence of intimate partner violence, which again was statistically significant after adjusting for those control variables. Infant prophylaxis, very similar story here. So more women were offered this medication, which is interesting. Around 61% reported exposure to intimate partner violence. And of those who were not adherent, almost 42%, of those who had experienced intimate partner violence, almost 42% were not adherent to giving the infant HIV prophylaxis medication. And again, definitely statistically significant, looking at those prevalence ratios of women who were not adherent having almost 3 times the prevalence of intimate partner violence. Another thing that I looked at, which I think is unique and interesting, is a potential dose-response relationship between intimate partner violence and all of those outcomes. But what emerged in particular was with HIV medication adherence, where my data indicated that women who had more frequent exposure to intimate partner violence, as well as experiencing a greater number of intimate partner violence events, appeared to have worse medication outcomes during pregnancy, postpartum, and infant prophylaxis. So you can see the different categories there and a visual display of what looks like a potential dose-response relationship. In terms of infant feeding, I categorized adherence to infant feeding as women who were breastfeeding and reported not introducing complementary foods until 6 months, which is not very culturally normative in this setting, but they have been pushing this. So 319 out of 320, because there was one person who didn't answer these questions. We have some missing data there. But of those, again, about 61% experienced intimate partner violence. And of those who experienced intimate partner violence, close to 50% were non-adherent to following those specific infant feeding guidelines. Again, statistically significant after controlling for the variables. And women who were not adherent had close to 2 times the prevalence of intimate partner violence. The final outcome that I looked at was exposure to intimate partner violence and adherence to infant HIV testing. There were 293 women who reported having been offered pediatric HIV testing for the infant. Around 60% reporting intimate partner violence. And then of those who had experienced intimate partner violence, more than 25% were non-adherent to taking the infant for infant HIV testing. And again, our prevalence ratios indicate that of those who were not adherent, they had 2.3 times the prevalence of intimate partner violence after controlling for those confounding factors. So often when I talk about this research, people will ask me, why? Why do you think there is this association? I mean, I think this cross-sectional data with its limitations does provide compelling evidence of a potential association. And originally, what I had hypothesized was that HIV status disclosure was a mediating factor in this relationship, where women who were in violent relationships did not disclose their status because they were fearful of violence, which would lead to non-adherence. However, I ultimately didn't find support for this hypothesis. So in all of the models that I presented, I ran 2 separate models where I first excluded HIV status disclosure as a covariate and then included it as a covariate. And across the board, those associations between intimate partner violence and the outcomes remained statistically significant and did not change in any meaningful way. However, what I did find was that HIV status disclosure appears to be independently associated with those outcomes. So this leads to kind of the conclusion that we need more research on this and what the mediating factors are. But it does look like both intimate partner violence and HIV status disclosure are independently associated with those important protocols of medication adherence during pregnancy and postpartum, the infant prophylaxis, HIV, infant feeding, and HIV testing. So in conclusion of this first piece, the study, in my opinion, and the opinion of these peer-reviewed publications, has provided some compelling evidence of an association between exposure to intimate partner violence and women's HIV-related behaviors during and after pregnancy within a high prevalence, low resource setting of sub-Saharan Africa. I think another really critical piece of this research is that it highlights how macro level determinants of gender inequity can translate into social interactions and interpersonal dynamics that lead to suboptimal health behaviors. And based on these findings, what I have been advocating is increased attention to intimate partner violence. Do you have a question?
When you finish, yeah. I just have a question about the determinants of intimate partner violence in this community, if you could mention that.
Yeah.
Because I don't know about this specific
Absolutely.
The predictors.
So the determinants of intimate partner events, the theoretical framework that I used was the theory of gender and power. So there are sexual divisions of labor, sexual divisions of power, and then inequitable gender norms in this community where intimate partner violence is both highly prevalent and highly accepted. So I think just the existing context of gender inequality where women have lower educational attainment. So that means they're often economically reliant on the male partner. So if they end up in abusive relationships, they often are stuck in those relationships. It's also a patrilineal society where women traditionally have left their home to come and live in the male partner's home. And traditionally, things have changed a little bit. The land and the children belong to the man and his family. So again, in situations of intimate partner violence, there are disincentives to leave those relationships and also give men a bit of a pass. As well, along those same lines, marital rape is not criminalized in Zambia, so a woman cannot be raped by her husband. So there's definitely that legal structure as well that creates some of these dynamics. And let's see, there was one more piece I was thinking about. I can come back to it. But that's sort of some of the determinants, I think, that lead to intimate partner violence in these relationships. That the country of Zambia, I do have to give them credit, at least on paper, is trying to address. And one of the goals of this project was to hopefully provide additional motivation to the need to address this because there are potentially these far-reaching HIV-related outcomes.
Question?
Yes.
So I'm actually going to ask if we could let her get
till
through
the
her
very end.
talk and hold questions till the end.
Yeah.
Sorry.
Yep. So I have one more study to present on briefly, and then I'm happy to answer questions about either of these projects. So for the second study, slightly different setting. It is more of a peri-urban setting in southwestern Kenya. The counties of Kisumu, Homa Bay, and Migori is where this research took place. And smaller population, overall about 300,000 people live in this area. And this is a map of HIV prevalence rates, with darker being higher prevalence. And the dark red is where this data collection took place. So overall in Kenya, it's estimated HIV prevalence of about 6%, but in this region where our data collection took place, the HIV prevalence is closer to 15%. And again, this is based on a cross-sectional survey with 200 postpartum women. This was a sub-study for my postdoc, my first postdoc, that is under the umbrella of one of my mentors' R01 studies, which is the Mother-Infant Visit Adherence and Treatment Engagement Study, or MOTIVATE. And this may look familiar to some of you. You may have seen this before. I'm actually using this data. I previously worked with one MPH EPI student, and I'm currently working with an MPH EPI student using this data for their capstone projects. And this work, some of the interesting things that have started to come out of this are using the outcome of viral suppression, which I think is an improvement from the previous study. This is a biomarker that is often used as an indicator of women's optimal treatment. And if they have a viral suppression of less than 1,000 copies per milliliter, they're considered virally suppressed. And then the exposures that we've been looking at include more mental health issues. So depression, major depression, and internalized stigma have come out as being important in this relationship with women's viral suppression. And then lastly, using this data, one of the things that I've been able to do, and I'm really excited about it, is develop a male partner involvement scale, which I'll present on how I've been doing that as well. So not only looking at what some of the barriers are, but also looking at what some of the facilitators are, and, intimate partner violence being a negative, but there also are behaviors that male partners do that are supportive, and measuring that is important. So the parent study that this survey took place under is a cluster-randomized trial with a 2x2 factorial design. And this is an NICHD R01 study led by Dr. Abugi. And they are looking at the combined and individual effects of these two specific interventions using community mentor mothers and using text messaging to try and promote optimal adherence and retention in care among pregnant HIV-positive women and then throughout the postpartum period. And for my sub-study, this is just relevant because the survey that we administered included women in all 4 study groups. So women who were receiving both interventions, only community mentors, only text messaging, and then the control standard of care. And I did control for intervention exposure in the analysis. So again, of the 200 women we sampled, we had data on their viral suppression during the study period for 198 of them. And this comes from medical records that were collected for part of that Motivate trial. Very high level of major depression was reported, where close to 26% of the women screened positive using the PHQ for major depression. And of those who had experienced major depression, close to 12% did not have viral suppression. Now, the first time I ran this model, controlling for factors of age, education, parity, using electricity as an SEX proxy, and intervention exposure, I did not find a significant relationship. What became interesting, however, though, was through further analysis, when controlling for internalized stigma in the model, the prevalence ratio went from 1.9 to 3.7, essentially, and the relationship then became statistically significant. So what this has indicated is that it looks like there is this very important potential relationship between major depression and women's HIV-related stigma, and that in this model and in this sample, internalized stigma may be an important precision variable explaining the relationship between major depression and women's viral suppression. So then, I warned you at the beginning, this is a lot of material. Moving into this male partner involvement scale that I have developed, I just wanted to present a little bit of research on this. So what we did on this survey in Kenya was we had a module regarding male partner involvement, and it consisted of 10 questions that I put together based on the existent literature and also hypothesized associations based on theoretical social support and things like that. So we asked women how frequently their male partner encouraged a facility delivery, encouraged infant testing, encouraged infant, reminded about infant medication, reminded the woman to take her medication, reminded her to go for care, gave her transport money, encouraged specific infant feeding, actually gave the baby the prophylaxis, came to healthcare visits, and collected HIV medication for the woman or the baby. And this is in order of the frequency that these behaviors were reported. So we used a 6-point unidirectional Likert scale to capture participant responses. They're condensed here for ease of visualization into 4 categories. And using participant responses on here, I created a scale based on averaging the frequency of each item. And they were given equal weight. So essentially, the higher the score, the more involved the male partner was in these behaviors. So then, this was the first time that I have attempted to get into some psychometric analysis, which I'm excited about. So we looked at some of the underlying latent factors, as well as the internal reliability of the scale, and then some of the construct validity using the existing variables and data that we had. And through principal component analysis, I explored the variance in the sample and some of the potential underlying latent factors. And what came out of the analysis using Cattell-Scree and Kaiser-Gutman criterion is that it looks like it is a two-factor subscale situation where we have encouragement and reminders being one subscale, and then active participation being another subscale. So based on the Kaiser-Gutman criterion, it looks like there are these two different factors underlying in the scale before the elbow happens. And then I looked at the Scree plot both before and after orthogonal rotation, and it had a similar structure there. So there are these three different scales, essentially, that I've been looking at now. You have the overall male partner involvement scale, their encouragement and reminder subscale, and the active participation subscale. And all of the items were retained based on their factor loadings. I didn't have anything less than 0.4, so they were all retained, which I think with a larger sample and maybe more questions on this construct, we would probably see different. And so the first subscale consists of 7 items that I labeled encouragement or reminders, because this includes things like encouragement to have a facility delivery, encouragement for specific infant feeding, reminders to take medication and go for care. And then the second one only has 3 items, but appear to all be related to active participation of the male partner. So things like actually attending healthcare visits, collecting the medication, or giving the medication to the infant. And what appears to be promising is, a bit more on this. So the first 2 scales, the overall scale and the encouragement and reminders subscale, both have means that appear to be in the moderate to high range, and also have high internal reliability based on Crobox alpha. However, the active participation subscale tends to have means that are towards the lower end, which might not be surprising because that takes a bit more effort on the male partner. But it also didn't hold up super strong in terms of the Crobox alpha and the internal reliability. Again, it is only 3 items. So the last piece of this analysis was looking at the construct validity of the scale and what associations exist using linear regression analysis, using ordinary least squares to look at individuals' mean scores, and then these, what you would think would be associated with that. So some of the psychosocial factors I looked at and their association with the overall scale and the 2 subscales are individuals' internalized stigma score. And these are the ones that came out as being significant. Relationship satisfaction, we had another scale that measured individuals' relationship satisfaction. We also measured both positive and negative aspects of male social support. And then there were these important couples level HIV related behaviors that we also asked about on the survey, which includes HIV status to the male partner, as well as whether or not the couple has ever been tested for HIV together as a couple. And what came out of this data is that internalized stigma appears to be negatively associated with the overall male partner involvement. And these are the beta coefficients and confidence intervals from the multivariable models. And then these other factors, relationship satisfaction, social support, HIV status disclosure, and the couple testing together as a couple appear to be positively associated, which is what you would expect. Internalized stigma did not hold up to be associated with the subscales, but both of these relationship dynamics pieces, as well as the couple's HIV behaviors, appear to be significantly associated with the the subscales, which I think is promising. And again, this is very preliminary work, but it does look like this scale of male partner involvement appears to be measuring what we would expect it to be measuring, and there is evidence of construct validity. Some of the limitations and strengths of these projects before I talk about just briefly my future most recent project. Limitations are that both of the data are based on cross-sectional surveys, which we can't establish causality around. I think there are hypothetical directions that exist, but of course the nature of the data doesn't allow us to definitively say that intimate partner violence happened first and then the woman had non-adherence to these behaviors. Another limitation is that they both are specific populations with limited generalizability. So in the first study in Zambia, those are low socioeconomic urban women living with HIV. So I don't think we can generalize that to all Zambian women, all African women, because those in higher SES or rural settings are likely to have very different experiences. And then in the Kenya sample, those women were all enrolled in that larger trial, which also limits generalizability outside of that particular sample. In addition, self-report has known biases of social desirability and recall bias, and we definitely try to, as much as possible, address those biases in the sample. So we try to normalize questions by saying things like, women often have a difficult time remembering to take their medication. Many women experience, these type of things. Did you then, instead of just jumping into, are you adherent to your medication? And then we also tried to triangulate as much as possible the reports on the surveys using available medical records. Some of the strengths of these projects are that much of the research only asks about one time period, either breastfeeding or pregnancy. And although this was a cross-sectional study, we did ask about behaviors across that continuum of care. The other piece that I believe is a strength of the first study is it's a comprehensive intimate partner violence assessment. Again, a lot of work focuses only on physical violence, which in my research, I looked at the different types of violence, and emotional violence actually appears to be one of the more significant factors. And then some of these more advanced techniques of looking at dose-response relationships as well as potential mechanisms and interactions are important. And then the use of biomarkers, and finally adding to the literature this new male partner involvement scale, which people talk about as being important, but we don't really have a great measurement to capture that construct. And then moving forward with this research, for the next project that I'm working on, and this is through an NIMH K99 ROO, I am excited to be moving into the world of intervention development and hopefully trying to target and improve some of these interpersonal dynamics and mental health and psychosocial factors that appear to be important to HIV, pregnant, and postpartum women's medical adherence. So what we're doing is I'm currently in the process of refining a couples counseling intervention. So we're doing qualitative work in Zambia right now with pregnant women living with HIV, their male partners, and service providers, and using models from the region that have proved to be effective to try and adapt it and make sure it's culturally appropriate for the Zambian setting. And starting in 2020, the plan is to enroll 238 pregnant women who are living with HIV and their male partners, and it will be a one-to-one randomization where they will, in the intervention arm, receive the proposed intervention, which we're still working out the details around exactly the material that they will receive and the frequency of interactions, as well as the location, do we do it in the home or the clinic, etc. And the control condition, originally NIH had pushed for a time-matched control with couples, but what I actually might try and propose to my program officer, because I'm also working on a systematic review, and what's coming out of that is we don't really know if a couples-based approach is actually better than an individual approach. So what I would like to do is have similar material as much as possible presented to couples and have couples work on their skills, and then have in the control arm a matched sample, but only women who are receiving the intervention. And I think that would then hopefully provide some interesting evidence whether or not doing a couples-based approach is, cost effective and results in better outcomes than just working with women. But the idea behind the intervention is that it will be adaptive. So we'll take baseline characteristics around what's going on with HIV-related health behaviors, as well as those couple dynamics, mental health, stigma, and those factors. And depending on how women score on those baseline characteristics, they'll receive a slightly different intervention. Because I think in intervention research, it's increasingly becoming clear that a one-size-fits-all approach is not cost-effective nor the best in terms of outcomes. So, for example, women experiencing intimate partner violence may have different counseling than those not experience violence. Those who are adherent will have different counseling than those who are not adherent and haven't disclosed their status, et cetera. And the hypothesized pathways here are that if we can hopefully improve relationship dynamics and support within the home, the couple will have better supportive interactions and perceived social support, as well as improved motivation and improved couple coping in terms of dealing with HIV within the relationship, which will then lead to these improved health behaviors. And the final outcome that I will be collecting is maternal viral suppression is the primary outcome that we'll be looking at. But we'll be looking at secondary outcomes of mother-to-child transmission, those self-reported behaviors, as well as men's uptake of HIV services. And just a bit acknowledgments about the funding for these projects. My primary mentors, Lisa Boogie and Sheena Bull, those who helped with my predoctoral and postdoctoral research. And then, of course, the local research assistants and participants, without whom this work would not be possible. And thank you very much for your attention. This is my favorite picture from Zambia, just happy mama and baby. I'm happy to answer any questions about any of that. Thank you.